All right. So why don't I start with this question? I think maybe I will direct this towards, Sarah, I'll start with you, and if others want to chime in. So older adults are not digital natives. Doesn't that make it more of a challenge to develop technology for geriatric health versus younger people where the barriers are lower?
Absolutely, it does. But you'd be surprised at how adaptive people are. We have found that it's less and less of a barrier all the time. Making universal design available and principles in either a smartphone or on the web is critical to making things usable. But I think, as Dilip showed, people are very willing to adopt technology and are interested in what the newfangled thing is. So it's less of a challenge, I think, than you would think.
Uh, Making a case for using the technology is critical. I think older adults are less likely to have exploratory use of technology, but if it's critical and you can make a use case for it, adoption rates are fairly comparable to younger adults.
In my experience, the critical component for us developing these smartphone apps was to focus group it with these participants. We learned a tremendous amount. There's just a few characteristic things that older folks don't like. They don't like surprises on the devices while they're using them. That's a big no-no. So we had to pretty much start over from scratch. We thought we were very clever and had this figured out, but actually sitting down and testing it out with old people was a huge critical step for us.
Yeah, I think that testing out part is actually a really good point. Some of the games that people assume are engaging for younger people may not be so engaging. I've a researcher out of Florida was evaluating whether older people like the games of violence, the shoot 'em up games. They hate that. Finding more socially nurturing kinds of engaging games are much more likely to be successful.
Great. Thank you, guys. Thanks for the question. So, Dilip, I'll ask you this question if you can hear me okay. Seniors are often concerned with privacy and security, and how do you get this group to adopt digital health when they're so wary of these concerns? Why don't one of you guys answer that question?
Yeah, it's very interesting because ARP's very aware that older people are subject to scams, and we're trying to balance, making people aware of some of the privacy concerns when dealing with technology. But it's about creating trusted information, making sure that people are understanding who is reaching out to them and building that level of trust over time, and making sure that what you do with their personal information, you're letting them know, they're seeing it, and you're treating it with respect and confidentiality.
And I would add transparency and control to that. We found in our work that you can convince people of the value of continuous monitoring, for example, if you give them the ability to turn it off. So I think if people have control over when they're monitored and when they're not, they're much more apt to go with it. And I think transparency is the second thing. I think knowing what's being used, where the data are being stored, who is keeping the data is crucial. We did a little project looking at privacy apps for dementia, and we think there's a serious issue there with lack of clarity of what's actually happening with this information. So I think transparency and then giving the people being monitored the control over what's being monitored and how, I think, is crucial.
Great. So, Jason, this is a question for you, but I'm going to add a second, maybe a part B to it as well. So one is, do you have any independent validation that day-to-day fluctuations that you were mentioning are clinically meaningful? And the part B to that question is, do you think that some of the really disappointing negative clinical trials, if you will, in mild to moderate AD with some of the amyloid-targeted therapies are actually related to some of these issues with measurement?
Yeah, so the answer to the first question is that's one of the aims of our grant that we're looking at, is to determine whether disease effects are underlying the variability that we see. But right now, we don't have a lot of evidence to support that. There are other things that we're considering too, like time of day effects. And the answer to the other one is yes. I think a lot of the trials have missed precisely because they were underpowered. In order to get a drug approved in Alzheimer's disease, you have to show a cognitive benefit depending on what the indication of the disease. If it's for secondary prevention, you have to show a cognitive benefit. And there have been a number of trials that have just missed because of unexpected variants that had occurred in the placebo group, for example. So they probably are working, but they just didn't detect it because they were underpowered.
I'll just reinforce that last point about how these trials just missed. We've been involved in a number of these really lengthy secondary prevention trials and also some of the trials of patients with disease. And the clinical benefit, of course, you don't know what patients are on, but we've had people on open label treatment for up to 5 or 6 years with relatively remarkable stability of symptoms and a significant change after drug was withdrawn because the trial failed. So I think we need to do, I mean, the work you're doing, Jason, is going to really have a huge impact in terms of our ability to interpret these trials. I'm going to ask one more question.